Distal tibia intra-articular fractures are also called pylon fractures. These kind of injuries is challenging because of its subcutaneous location and precarious blood supply and proximity to the ankle joint. The goal of treatment involved healed, well-aligned, functional range of motion of ankle. Careful management is needed in these cases because of the soft tissue involvement, appropriate reduction, maintaining alignment and joint line congruency is the most important factor. The aim was to analyze the outcome of communicated intra-articular fracture of distal tibia with the external fixator. This was a retrospective study, included 30 patients, 23 male and 7 female, done at our tertiary care center in a duration of 2 years. Inclusion criteria included of age group of 20 to 60 years. Patients with open and closed both fractures were included. Patient with vascular injuries, pre-existing deformity of tibia and associated other fractures were excluded. So according to my study, the results were evaluated by American Orthopedic Foot and Ankle Society scoring, and results were average functional score was 76 points and complication occurred in 4 patients. The final range of motion averaged 10 degrees of dorsiflexion and 28 degrees of ankle plantar flexion. They were assessed on the ankle, foot and clinical scoring and on the radiographic assessment and graded accordingly: excellent, good, fair and poor. So I'll jump to the x-rays. The first case, this is the first case. These were the preoperative x-rays showing distal tibia and fibula fracture. This is the preoperative CT scan. Patient was having distal tibia compound grade B for which VAC dressing was applied. This is the wound status after removing the VAC dressing, and he was operated with a external fixator delta frame. This is immediate post-op x-ray. These were the status of x-rays on 3 months follow-up, and these was after the removal of the fixator. The patient was kept for below knee cast for 1 month after the removal of fixator and then mobilized. Then the ankle was mobilized. This is another case showing distal tibia fracture intra-articular managed with external fixator. These are the immediate post-op x-rays. 3-month follow-up, after which below knee cast was given for 1 month and then cast was removed and patient ankle was mobilized. Same case, same fracture managed with external fixator, and in this case we had put one percutaneous CC screw. 3 months follow-up of the x-ray, and this is the status after the removal of the external fixator. So in conclusion, the results focusing on the approach of external fixator were found to be good and applied for other clinical studies as well. And in discussion, I would like to say that the external fixator allows a better stabilization, less soft tissue dissection, and less periosteal stripping, and infection rates were much more common than the internal fixation. Only drawback I found was that the external fixator was a little cumbersome for the patient, and there were superficial pain tract infection in some patients.
Thank you, doctor.